Hello students, this is Dr. Kobikha, Assistant Professor from the Department of Oral and Maxillofacial Surgery, Vinaya Mission Sankaracharya Dental College and Hospital, Salem. Today we shall discuss about the very important and interesting topic of management of orbital floor fractures. So coming to the introduction, the orbits are a pair of pyramidal shaped bony cavities. They are located one on either side of the root of the nose. They also provide the sockets for rotatory movement of the eyeballs. So each orbit is a four-sided pyramid with apex directed behind the optic canal, the base forward, and they are represented by the orbital margin. The medial walls of the two orbits, they are parallel to each other, whereas the lateral walls are at right angles to each other. Coming to the anatomy, the orbit is a unique bony structure that has a primary purpose of housing and protecting the globe. So by the age of 5 years, your orbital growth is 85% complete, and the growth is finalized between 7 years of age. And the bones forming the orbit are, there are totally 7 bones forming the orbit. They are the maxillary, zygomatic, you can see in the diagram, maxilla, zygoma, the frontal bone, ethmoidal, lacrimal, palatine, and the sphenoid bone. This is very important, the 7 bones forming the orbit. Then walls of the orbit. There are 4 walls of the orbit, the roof, the medial wall, floor, and the lateral wall. So when you see the diagram, it will be easy for better understanding. The roof, it is formed by the orbital plate of the frontal bone. Can you see here? Orbital plate of the frontal bone, and it is completed posteriorly by the lesser wing of the sphenoid. And the medial wall, it is formed by the orbital plate of the ethmoid, the body of the sphenoid, please see here, the body of the sphenoid, lacrimal bone, and the frontal process of the maxilla. If you learn with the diagram, it will be easy for you to understand. The floor is formed by the maxilla and the zygomatic bone laterally. And the lateral wall is formed by the greater wing of the sphenoid and the frontal process of the zygomatic bone. Then, what all structures will occupy the orbit? There are a few structures which occupy the orbit. They are the eye, globe, the orbital fat. Can you see here in the diagram, orbital fat? It is yellowish in color. Then the extraocular muscles. Regarding the extraocular muscles, we will see in the later slides. Then the ciliary parasympathetic ganglion, the nasolacrimal apparatus, the optic nerve, that is your cranial nerves, optic second, oculomotor third nerve, trochlear 4, and abducens sixth nerve, V1, V2 branches of the trigeminal nerve, that is your ophthalmic and the maxillary divisions of the trigeminal nerve, and then coming to the ophthalmic vessels. Can you see here in the diagram? And the orbits, they have an average height of 35 mm and a mediolateral width of 40 mm. See, now we look to the volume. The intraorbital volume of the adult is 30 centimeter cube. So this volume is intraorbital volume, whereas the volume of the globe is 7 centimeter cube. So know the difference. Generally, the orbit and the globe volumes are bilaterally symmetrical at any stage of the growth. The medial walls are parallel to each other and they are around 45 to 50 mm in length, whereas the lateral walls are around 90 degree to each other and they are 40 to 45 mm in length. I hope you will understand when we saw in the first slide. The medial walls are parallel to each other, whereas the lateral walls are at right angles to each other. And then muscles of the eyeball. So there are extraocular muscles, there are voluntary muscles and involuntary muscles. In involuntary muscles, we have 4 recti, 2 oblique, and 1 levator palpebrae superioris muscle. So what are the 4 recti muscles? We have superior rectus, inferior rectus, medial rectus, and lateral rectus. And the 2 oblique muscles are the superior oblique and the inferior oblique, and 1 levator palpebrae superioris. We also have the voluntary muscles. They are smooth muscles. There are superior tarsal, it is also called as Muller's muscle, inferior tarsal, and the orbitalis. Okay, and moving on to the movements. So the orbit have some few movements, that is elevation, depression, abduction, adduction, intorsion, and extorsion. So few muscles will have few movements. So your superior rectus, they have elevation, they do elevation, adduction, intorsion, whereas your medial rectus do adduction. Your medial rectus is adduction, your lateral rectus is abduction. So like that, superior oblique, inferior oblique, they have some movements. Okay, and here there is applied anatomy in your muscles. When you have here applied anatomy called squint, that is medial squint and lateral squint. If the muscles get paralyzed and the corresponding nerve is involved, you get squint. Okay, then now we saw the anatomy. Now moving on to the classifications. There are few classifications given by few authors. So for the classification, first classification, Manson and colleagues classified the fractures based on the energy of the impact, the degree, extent of comminution, and the displacement observed on the CT. So the 3 fractures low velocity, intermediate velocity and the high velocity. So the low velocity fractures is also called as trapped out fractures. Intermediate is medial blowout fractures and high velocity is lateral blowout fractures. And the second classification given by Converse and Smith, they termed their fractures as pure and impure. This fracture is given based on the involvement of the orbital rims. So pure, it is blow in and blow out fractures. So what is pure fractures is, there will be fractures of the internal walls but the rims will be intact. Okay. Coming to the impure fractures, the rims will also be fractured. Please note, kindly note the difference. In pure fracture, there will be fracture of only the internal walls and their orbital rims will be intact. Whereas in the impure fracture, there will be complex with involvement of one or more rims, associated fractures of the rims. Can you see the diagram? Picture pure is A and C and impure is B and D. Then the third classification given by Hammer, he described 4 classes of orbital fractures based on their occurrence with the other fractures of the face. Type 1 is orbitozygomatic fractures. The name itself suggests it is the fractures of the orbit and the zygomatic complex. So these fractures involve the walls of the orbit along with the zygomatic complex. The second fracture is internal orbital fractures. Here, isolated fractures of any of the walls, roof and the floor. Then type 3, again the name suggests naso-orbito-ethmoid type fractures. So these fractures involve the fractures of the naso-orbito-ethmoidal complex involving the orbit. Type 4 is complex fracture of the face. This type involves fractures of the orbit with concomitant fractures of the face other than ones mentioned above. Okay. Then another classification given by Converse and Smith in 1960, they gave the phenomenon of blowout fractures. And one more classification given by Dingman and Natwig in the 1964, it is blow-in type of fracture. So here, what is blowout fractures? Here, there will be entrapment or herniation of the periorbital tissues. See, can you see the entrapment or herniation of the periorbital tissues? And so your eye movements will be restricted and our enophthalmos due to the reduction of the volume of your intraorbital content. This is blowout fractures. So what is blow-in fracture? Given by Dingman and Natwig in the year 1964, here the intraorbital space is reduced by an internally displaced bony fragment. So the bony fragment is displaced internally. So these type of fractures are usually accompanied with propoptosis on the affected side. The propoptosis is nothing but the bulging of the eyes. Okay. Here picture A demonstrates the blowout fracture of the medial orbital wall and the floor. Picture B demonstrating the blow-in fracture of the orbital roof. So far now we have seen the anatomy, classification, now moving on to the biomechanics of injury. So one of the first mechanism of the orbital wall fracture was suggested by Pfeiffer in the year 1943 called the globe to wall theory or the hydraulic theory. Here there will be posterior displacement of the globe after sustaining a direct hit was propounded to transmit force along the walls resulting in the fracture of the thinner walls. And there are 2 more widely accepted mechanisms of the orbital wall fractures. So it was first proposed by King in the year 1944. The 2 mechanisms are, one is retropulsion theory and the other is the buckling theory. Buckling theory is also called as transmission theory. So what happens in retropulsion theory? There will be sudden increase in the intraorbital pressure. How will be the sudden increase in intraorbital pressure? It is caused by a direct hit by a large object and this creates stress along the orbital walls, resulting in fractures of least thickness. Okay. And moving on to the buckling theory, this theory explains the injury through a ripple effect created in the floor of the orbit. The ripple thus created causes compression in the anterior posterior direction and the resultant fracture at the posterior middle part of the orbital floor. Okay. Next, we will see the ophthalmic examination. The American Association of Ophthalmology advocated an 8-point ophthalmic examination which includes the following. So the first is visual acuity and visual fields, pupillary examination, extraocular motility and alignment, intraocular pressure, external examination or periorbital screening, slit lamp examination, fundoscopic examination and globe position. So what is visual acuity? This test for each eye is recorded using a Snellen chart. So this is a Snellen chart. Can you see the letters and the numbering here? So this Snellen chart, it includes the ability to read the letters, count the fingers, they have to perceive the hand movements and light perception. So first test. Second is pupillary examination. The pupillary examination is done to note the size, shape, symmetry and direct and indirect reflex to your light. Third, The swinging flash test, it is performed for relative afferent pupillary defect. Now, the fourth is the extraocular motility and the alignment. Here, the patient is first screened for all the 6 cardinal gazes, that is moving up, right and left, moving down, right and left. That is the 6 cardinal gazes. First checked binocularly for visions of both the sides and then checked monocular for the ductions. A thorough heterotropia check is also performed. Diplopia and restriction in gazes are noted here. So this is a Snellen chart, picture A demonstrating, can you see the letters and see the numbers? The second is the swinging flash light test and the third is the 6 cardinal signs of gazes, your eye movements, okay. Next, a force duction test. Clinically, a force duction test is performed under topical anesthesia to elicit the mechanical impediment for the movement of the globe. This may also be performed under general anesthesia intraoperatively. So first, what does these 2 pictures demonstrate? First, in picture A, the limbus is grasped, that is a sclerocorneal junction, and the picture B demonstrating the grasping of the inferior rectus muscle. Okay. Now, the Hess-chart examination. So, what is Hess-chart examination? It is used to measure the degree of the diplopia. Already the diplopia is present and you want to know the degree of the diplopia. So, here this test helps in to see which extraocular muscle is not functioning. So, it is done on every alternative day. The progress of the diplopia can be monitored. In this test, dissimilar objects are projected at each eye at 1 meter distance with the patient wearing a green or a red goggle. So, the red test object is held against a screen and the patient tries to indicate the position of the object by touching it with a green tipped wand. Okay. The result of his or effort is charted when the head is held still and moves the eyes from primary position to horizontal right and left extremes of the movements. Hope you understand the Hess-chart examination. And so, we have seen all the examinations given by the American Association of the Ophthalmology. Now, moving on to the clinical features in orbital trauma. So, what are clinical features we can see in the orbital trauma? First is periorbital edema. Can you see in the picture A, periorbital edema here? And then periorbital ecchymosis and the subconjunctival hemorrhage. See here. Then contusions, hematomas, subcutaneous emphysema with crepitus, and lacerations involving the eyelids, see the picture C, and injury to the canthal apparatus, both medial and lateral, neurological deficits of the infraorbital and the facial nerves. These are the common clinical features. Okay. Then what investigations we do? We take radiographs, Cardwell, Waters and Tones. Here only the bony structures you can see, okay, bony abnormalities, sorry, not the soft tissue abnormalities, okay. And this is blowout and orbital emphysema X-ray depicting here the blowout fractures of the orbital floor. So, now coming to the orbital flow fractures, here is also a classification given by Jacquerie for orbital flow fractures. So, what is the orbital flow fracture? They are the most common fractures of the internal orbit, either in isolation or concomitant with the other facial fractures. See the classification given by Jacquerie. There are 4 classifications. Category 1 is low, 2 is moderate, 3 high and 4 is also high. So, what happens in low? There will be defect of the floor or the medial wall. It will be like 10 to 20 mm within zone 1 or zone 2. See, can you see there are 3 zones, zone 1, 2 and 3. And in moderate, no, moderate and the third category, there will be the same, the defect of the floor or the medial wall more than 20 mm within zone 1 and 2, okay. So, what the clinical finding? In category 1, you will see no clinical finding, whereas in category 2 and 3, see, in category 2, there will be the infromedial strut of the infraorbital fissure will be present, whereas here in category 3, the infromedial strut of the infraorbital fissure will be absent. You can appreciate in the diagrams here. And the category 4 is, there will be defect of the entire orbital floor with the medial wall involving the zone 3. So, till it is involved till the zone 3. Here, the infromedial strut of the infraorbital fissure will be absent. There will be also posterior ledge of the floor also may be absent. Okay. This classification is very important. Then, which fractures of the orbit need intervention? Okay. So, when the acute injury to the orbit showing the enophthalmos, clinically enophthalmos, hypothalamus, so they need primary surgical intervention. So, the post-surgical outcome may be compromised with delay due to the progressive atrophy of the intraorbital fat. See the hypothalamus, picture 2 enophthalmos of the right globe. And for other type also we do treatment when there is severe restriction of the ocular motility with CT or MRI that scans no evident muscle entrapment or incarceration of the periorbital soft tissue. And white eye blowout fracture. Here a case, here there will be white blowout fracture. This is X-ray depicting for a child with severe restriction of the ocular motility vagal symptoms. The CT image, the patient had a history of orbital trauma. This is a sagittal view and the coronal view. that is a stringing trapdoor fracture of the orbital floor on the left side with entrapment of the inferior rectus muscle. Please kindly see here, there is entrapment of the inferior rectus muscle, okay. That is called white eye blowout fracture. Here, this is a clinical photograph demonstrating the white eye blowout fracture, restriction of the ocular motility in the left eye in the, so picture A and E shows the inferior, this is A is superior gaze and E is inferior gazes. The other gazes B, C, D, they show no abnormalities, okay. This is white blowout fracture. And indications. So for what type we did treatment? Defects of the orbital floor, often larger than 50% or greater than 20 × 20 mm of defect size, especially in the zone between the floor and the medial wall. Diplopia, we also do treatment. Diplopia which is non-resolving and persistent for more than 2 weeks due to the entrapment or fibrosis of the orbital soft tissue. So when we see indications, we also have contraindications. Contraindications, there will be ophthalmic injuries like retinal tears, hypemia. What is hypemia? When this blood will come from the orbit. Displacement of the lens, ruptured globe, avulsion injuries of the globe, etc. And there is loss of vision in one eye, and with the only eye seeing involved is also a fracture. And this is a case, there is a delayed management of a patient with isolated fracture of the floor and the medial walls. The CT scan shows the fibrosis and adhesion of your inferior rectus muscle to the residual posterior ledge, producing diplopia and the restriction in the superior gaze. So this CT scan images of the patient with internal orbital fracture. So see the top A, B and C. This is coronal and sagittal images demonstrating the isolated fracture of the left orbital floor and the medial wall. And the images D, E and F, it is post-operative images. The reconstruction is done for the defect with an anatomical orbital implant, okay. And surgery for special indication in orbital floor fractures. So what is enophthalmos? It is nothing but the displacement of the eyeball in a posterior direction and is attributed to the increase in the intraorbital volume. So it is proved that increase in the intraorbital volume by 0.5 to 1 cc would produce posterior displacement of the globe by 1 mm. And if enophthalmos of 2 mm or more may be clinically perceivable and warrants surgical intervention. So care should be taken to reconstruct the posteromedial aspect of the orbit. It is called as Hammer's key area to achieve the posterior projection of the globe. Here this is a case of delayed correction of the enophthalmos in a patient with orbital floor fracture. So picture A and B depicting the significant enophthalmos of the left globe, enophthalmos, and it is treated. After treatment, there is a good surgical outcome, picture C and D. And coming to hypothalamus. What is hypothalamus? It is also called as hypoglobus, and it signifies the downward displacement of the globe due to the interruption in the anatomical integrity of the orbital floor. So the clinical presence of hypoglobus needs to be differentiated from orbital dystopia, which essentially means that the entire bony orbit with its contents is displaced caudally, unlike hypothalamus, whereas only the globe is displaced caudally. So what is orbital dystopia? So orbital dystopia is the eyes will not be in the same line. And here there is a case report. So patient came with a history of facial trauma 8 months back, presented with complaint of change in position of his eyeballs. And the patient also had a history of surgical intervention for the management of the panfacial fracture immediately after the trauma. But there was no intervention performed for the orbital fractures primarily. So on clinical evaluation performed 8 months later, there was enophthalmos, hypothalamus and restriction in the superior gaze in the right eye of the patient. So after taking CT scan, the CT scans revealed a large orbital floor defect on the right side with fibrosis and adhesion of the inferior rectus muscle to the posterior ledge of the floor defect. And so the patient was subjected to secondary surgery for the correction of the above mentioned complaints. The orbital exploration was performed on the right side to release the inferior rectus. The infraorbital rim was augmented with ramal graft and the floor was reconstructed with the Stryker anatomical orbital implant. So the post-surgical evaluation, it revealed optimal corrections of the enophthalmos, hypothalamus and good repositioning of the inferior rectus muscle. So this is a picture, preoperative clinical photograph of patient demonstrating the right side enophthalmos and hypothalamus. So after surgery, though there is good optimal surgical outcomes. And this is a case, there is right side malunited zygomatic complex fracture with the orbital floor defect. So the post-surgical scan showing the reconstruction of the right orbital floor defect with anatomical orbital implant after augmentation of the intraorbital rim with a mandibular ramus bone graft. Okay. The other picture, that is CA to C, that is axial, coronal and sagittal scans of the patient where there is defect of the right orbital floor. Please see correctly. And this is post-operative. The floor is corrected with the anatomical orbital implant. Okay, the implant is placed. So this is a view, axial view, coronal view and sagittal view. This is preoperative and postoperative. After the treatment is postoperative. The implants have been placed. So diplopia. What is diplopia? Diplopia is a double vision, that's all. Generally, post-traumatic diplopia due to edema and hemorrhage is self-limiting and shows a spontaneous resolution. And it is of two types, monocular and binocular. So what is monocular? Here, the patient when seeing through one eye with the other eye is closed, okay, which is of more concern when the pathology is generally due to an ophthalmic problem, cornea and retina, or neurological, where the problem may be due to the optic nerve or the optic disc being injured. Binocular diplopia, here the diplopia is present only when seeing with both the eyes and is absent on seeing with one eye. And CT, it should be muscle entrapment as an indication for the immediate intervention to do. So other reasons for diplopia include intraorbital edema, hemorrhage and any bony spicules or fragments acting as impending following the trauma, and there might be entrapment of the periorbita, and in rare cases there may be large changes in the intraorbital volume including massive herniations or atrophy of the periorbital fat. They do not need immediate intervention. So what is the right time to intervene? So there are three timings for what cases we do immediate, early and delayed. So immediate it is done within less than 24 hours. So for white eye blowout fracture and CT evident with entrapment of the positive force reduction test and oculovagal response and vision threatening emergency. For these cases we do immediately within 24 hours. Whereas early, that is less than 14 days, is CT evident entrapment with positive force reduction test and non-resolving diplopia, enophthalmos and hypophthalmos, more than 50% or 2 cross 2 centimeter flow defect, we do early intervention. For the late interventions done for cases for non-resolving symptoms, late enophthalmos and hypophthalmos. So what is used for the reconstruction of the orbital defect? We use both autogenous and alloplastic materials have been used. So the materials used are the titanium, bone graft, porous polyethylene, composite porous polyethylene, resorbable plates and preformed anatomical implant. Okay, and there is also literature favoring the use of stock titanium meshes and custom made patient specific implants which provide optimal corrections. So the picture A is strike-cut preformed anatomical orbital floor implant, and B is titanium, that is patient specific implant. Okay, and guidelines for deep orbital dissection. So if you want to do deep orbital dissection, we have to follow these guidelines. Okay, so first, infraorbital nerve. The course of the infraorbital nerve within the orbit is a very important landmark in the orbital floor dissection. So the point of its entry is from the pterygopalatine fossa at the genu bend, where the infraorbital fissure takes a turn and ascends laterally to continue as a superior orbital fissure, signifies a safe limit for the posterior extent of the floor dissection. So even in case of badly communicated fracture or delayed corrections, the nerve may be identifiable and it gives a ready cure. Inferior orbital fissure. The inferior orbital fissure forms a pathway for an extended exposure of the lateral orbit, as the contents of the fissure can be safely divided using the bipolar cautery dissection. This facilitates easy navigation into the deep orbit behind the fissure and raise the greater wing of the sphenoid. Third, the greater wing of the sphenoid. It is thick and strong bone structure which forms the majority of the lateral orbit and bridges the inferior and superior orbital fissure. So it is less prone for comminution and hence forms a predictable landmark to find even in the severe trauma. The fourth is the orbital process of the palatine bone. Orbital process of the palatine bone forms the highest point of the posterior medial bulge of the orbital floor. This is an integral part of the posterior orbit that needs to be reconstructed to get adequate positioning of the globe in the anteroposterior and the vertical dimensions. The last is the orbital confluence. It is formed by the convergence of the two bony cells forming the genu of the internal orbital fissures. This signifies the safe limits of the dissection of the orbital floor. The confluence is formed by the perpendicular plate of the palatine bone on the medial aspect and the bony inferior margin of the greater wing of the sphenoid laterally. See here, the picture A demonstrates the landmarks on dry skull. So the A is nothing but the perpendicular plate of the palatine bone, B medial lip of the greater wing of the sphenoid, C is orbital confluence and O is optic foramen. This is structures of the deep orbit in a patient undergoing secondary surgery for low floor reconstruction with or implant replacement. So there are some safe distances within the orbit. So there is an important formula to remember the safe distances. It is 24, 2 and 6. 24 is the safe distance in mm of the anterior ethmoidal foramen from the medial orbital rim. So from the medial orbital rim it must be 24 mm distance. Okay. Additional 12 mm deeper would indicate the posterior ethmoidal foramen and the other 6 mm deep for the optic nerve, that is 24, 2 and 6. Globe protection. So protection of the globe is of very vital important in orbital surgery. Adequate care should be taken for the protection of the other vital structures like nerves and vessels also. There are use of protection devices like specific retractors and corneal shields. It is very mandatory. So you see here the striker globe retractor, synthesis globe retractor. Here it is the synthesis retractor is used in anatomical position, demonstrating the use of calibration to aid intraoperatively. Okay. So the recent advances nowadays, there is computer assisted surgery allowing the virtual preoperative planning of the desired reconstruction using the CT scans. So here first a virtual 3D model is generated here, and then we segment it and then mirroring of the normal side. 3. Superimposition of the mirroring image on the affected side, enabling a better understanding of the deformity. 4th is nothing but the creation of the patient specific implant designed for the frontozygomatic region and importing the virtual model of the anatomical orbital implant for the floor reconstruction. So patient specific implants, it is used for the reconstruction of complex defects and deformities have been nowadays. They offer good advantages of accurate planning and positioning intraoperatively, which improve the post-surgical outcomes. The implants may also function as a guidance stent and double up as fixation devices too. See here, this is patient specific implant for a floor defect and medial wall defect in the right side of the orbit. So here there is a frontal view of the patient specific implant, and this is the white color now, that is a stereolithographic model of the patient. This is superior view. This is intraoperative picture demonstrating the placement of the patient specific implant in situ. So what all complications will encounter? Complications with when we are doing the orbital fractures are, there will be immediate complications and delayed complications. What will be the immediate complications is edema, infection and wound adhesions immediately after we perform surgery. And later delayed complications will be persistent enophthalmos, hypophthalmos, worsened diplopia with altered vision. The ocular movement will be restricted because of the fibrosis and the adhesion. So these are the immediate and the delayed complications. Then last conclusion. So patients with orbital trauma, they need to be subjected to ophthalmic examinations both preoperatively and postoperatively. It is very important. The globe must be protected, gentle retraction of the tissues must be made, intraoperative testing for vision are mandatory during your orbital surgery. So what are the principles to be followed during the orbital floor reconstruction? So there must be complete exposure of the fracture and the defect should be exposed completely. Meticulous deherniation of the orbital soft tissues with restitution of the intraorbital volume. Identification of the posterior ledge in floor defects, which is the posterior limited reconstruction, and the restoration of the posterior middle bulge of the orbit, that is Hammer's key area. Thank you.